Well, hello everybody. Welcome to this question and answer session regarding Ledermix. This session has arisen out of a follow-up to a webinar that I presented a few weeks ago, where we had between 500 and 600 people listening to the webinar at various times. Out of that, we had almost 100 questions submitted, and some of the questions were answered on the night of the webinar, but we didn't have time to address all of them. So the purpose of this session is to answer those questions again in case people didn't hear them, but also to go through the other questions that were raised. Now, with that many questions, inevitably there are several themes that arose through the questions. So I won't necessarily be answering every single question, but they all contribute, as I say, to several themes, and I will go through those. So the first one is just some very general questions. There are several people wondering why the Ledermix products weren't available for a few years. The reason for that is that there was a supply problem with the antibiotic component, the dimethylcycline. So the manufacturers overseas decided that they would stop making it. Fortunately, the Ausdent company in Australia decided to take up the manufacturing of the materials, and they were able to source all the components and manufacture it. But because it was classed as basically a new material by the Therapeutic Goods Authority, TGA, and therefore it had to go through the whole approval process as though it was a new product. That's despite the fact that it's exactly the same formula to what we have been using for almost 60 years now, but because it's being made in a new factory, that was a TGA requirement. And that whole process takes a little bit of time and a fair bit of paperwork, so that's why there was some delay. So somebody did ask if the Ledermix products were TGA approved, and they definitely are. The companies would not be able to sell it in Australia if it wasn't approved. And you can always look up the details on the TGA website if you're interested. And some people ask, where can they get Ledermix materials? Well, pretty much all of the general supply companies in Australia will have it available now. And I just did a quick search this morning on the internet, and you can see in the online catalogues for the major companies such as Dentsply and Gunz and Henry Schein, but also some of the other smaller suppliers, Healthware Australia, Ridley Dental Supplies, Matrix Dental, Adam Dental, and so on. So I think you'll find it's actually fairly easy to get hold of through your usual dental supply company. The next, there were a number of questions asking about the indications for the use of Ledermix paste and Ledermix cement. And rather than go through every single indication tonight, and some of them will come up as we go through the questions, but I'll direct you again just through a simple search on the website. If you go to Google and put in Ledermix in Australia, one of the first things that comes up is a PDF brochure, or it's a little booklet that I was involved in writing a few years ago. And when I searched today, it came up under the Dentsply website, and it actually links straight to the PDF. And there's a copy of the brochure where you can get some fairly simple but also fairly detailed information about when and how to use the Ledermix products. Now, the main use of Ledermix paste will be during root canal treatment. It's a root canal medication, and it's particularly useful for dealing with inflammatory conditions. So things such as irreversible pulpitis, acute apical periodontitis, even during elective endodontic treatment, it's useful because it can reduce the inflammation that's created by the procedure itself. And it can also help to reduce the possibility of neuropathic pain, or if it doesn't stop neuropathic pain, it can usually reduce the amount of pain that patients will experience post-operatively. The main use for Ledermix cement is for things such as pulp capping, partial pulpotomies, and cervical pulpotomies. So where we're trying to preserve the pulp rather than when we're removing it. And again, the main purpose of using the Ledermix cement is to have the anti-inflammatory effects of the corticosteroid component. And then, as I explained in the webinar, the Ledermix cement contains calcium hydroxide. It makes up about 33% of the powder, so we get the effect of the calcium hydroxide. And also the liquid part of the cement is eugenol, and a major part of the powder is zinc oxide. So it's effectively a zinc oxide, eugenol, calcium hydroxide, corticosteroid antibiotic compound. And the eugenol can also have therapeutic effects on the pulp when it's inflamed, as I explained in the webinar. Now, there was some concerns raised or questions raised about whether it's safe to use these products during pregnancy and what to say to a patient if they were pregnant and they were concerned about the effect on the developing fetus. Well, in a paper that I wrote in the International Endodontic Journal in 1990, I outlined that the concentrations of both the corticosteroid and the tetracycline components of Ledermix that come out of both the paste and the cement and reach the systemic circulation are virtually negligible. There are very, very small amounts which will work in the local situation, in other words, around the tooth or within the pulp. But once the drugs actually reach the systemic circulation, they're diluted by many, many thousands, probably even millions, or a factor of a million or more, so that the amount of circulating antibiotic or circulating corticosteroid is pretty much negligible. So the materials are definitely safe to use during pregnancy. Another theme that came through from some questions were regarding some of my recommendations regarding treatment times and the timing between appointments. Now in the webinar I explained that I like to leave my medicaments in the root canals for 4 to 6 weeks, and particularly related to Ledermix paste, that is, because we're talking about root canal treatment. You need time for the periapical tissues to heal. Now we know that inflammation in soft tissue takes 10 to 14 days to heal. So if you cut yourself, for instance, you could expect that cut to take around 10 to 14 days for it to heal. And in the first week or so, you may have some sensitivity associated with that injury to the skin. When we're talking about root canal treatment, we're not talking about soft tissue because we've removed the soft tissue during our procedure. So we're dealing with the hard tissue, in other words, bone, and also the periodontal ligament. Now, healing in bone and periodontal ligament takes much longer than it does in soft tissue. And so ideally we need to allow time for that healing to occur before we do more treatment. Every time we do some treatment to a tooth, we will create some inflammation in the periapical tissues. So if we allow the inflammation to resolve before we irritate it again, there's less likely to be post-operative pain for the patient. You just think of if you were to, say, cut yourself, as I mentioned before, and then if you knock that, say, cut finger a few days later, it actually hurts more than when you actually cut it. And that's because there's already inflammation present. So if that inflammation lasts for several weeks, then it's best to allow time for that to heal before you go in and continue the treatment. With the Ledermix paste, we have done studies years ago now that showed that it can maintain therapeutic levels within a fully developed tooth for up to 6 weeks, in an immature tooth about 4 weeks before it reaches a sub-therapeutic level. So it certainly keeps contributing to the healing response over that period of time. One question, again, dealing with medicaments, time for treatment. Somebody asked, can they do just 2 weeks of treatment when there's a non-infected tooth? So I assume there they mean pulpitis, or when it's elective root canal treatment. As I said before, 2 weeks would be the bare minimum that I would leave it for, because we need longer for bone and periodontal ligament healing to occur. That raised a couple of questions from some listeners regarding temporary restorations during that inter-appointment period. Now, some were concerned about the possibility of the temporary restoration breaking down. Well, that depends on the type of material you use and also how you go about preparing the tooth. Now, I'm a very firm believer, based on research that we've done through our team here at the University of Western Australia, that you really need to remove all the restorations that are in the tooth, because inevitably there's going to be some caries or breakdown of the restoration, or perhaps cracks under the restoration that you can't see until you remove the restoration. So the very first stage of treatment for me is what I call investigation, where we're removing all the restorations, the caries and the cracks, And that means that we then need to build up a fairly comprehensive interim restoration. In posterior teeth, that usually involves using a glass ionomer, and very often with a stainless steel band. Not all teeth will need a band, but the band acts as a retention device to keep a very stable interim restoration. So if the interim restoration is done well, it's unlikely that it's going to break down in that short period of time of 4 to 6 weeks. At subsequent appointments, I'll make an access cavity through that interim restoration, and there I will use a 2-layered temporary restoration at the end of that appointment. So firstly, I'll place a very, very small piece of cotton wool on the floor of the pulp chamber just to block the canals. Then we'll place CAVIT, and then we'll place IRM. So approximately half the depth of the access cavity would be the CAVIT, and then the outer layer, outer half of the access cavity would be IRM. IRM is a great material because it's antibacterial. It's also quite insoluble, particularly compared to CAVIT, and it has reasonable strength and wear resistance. If you just use CAVIT, then you could expect that that restoration is going to wear down. It is somewhat soluble, and if you don't have a thick enough layer, then that restoration certainly could be problematic. So using that double layer or double seal temporary restoration in the access cavity, to me, is essential to use. Another question then, again related to appointments. This person said that studies show single visit root canal treatment has a higher success rate than multiple visit root canal treatment. So where does Ledermix stand on that? Well, actually, I disagree. I don't think there are other studies that show single visit treatment is or has a higher success rate than multiple visit. One of the reasons we use more than one appointment is to gain the effects of our medicaments. Now, depending on what the diagnosis is, if we're dealing with pulpitis, for instance, we're trying to reduce inflammation. If you complete the treatment in one appointment, you don't have the ability to help with the anti-inflammatory action that you want in the periapical tissues where you've severed the pulp. And as I mentioned earlier on, when you sever the pulp, there is a possibility that you can develop neuropathic pain afterwards. So the use of corticosteroids can help to avoid that. In infected teeth, or what I refer to as infected root canal systems, then we can clean the root canal quite effectively because that's easy, but it's the rest of the root canal system, so the dentine tubules and the fins and the isthmuses or the connections between the canals in one root, are areas where bacteria certainly can be, and many studies have shown bacteria in those areas, and we can't get to them mechanically, nor can we get to them without irritants. So the medicaments play an essential role in destroying any remaining bacteria that are within the tooth root, within the dentine. And by placing a medicament in between appointments, we make our treatment a lot more predictable. And I think that's the most important part, is that we think about predictability of treatment. It's also very practical because if there are problems, for instance, if the pain doesn't resolve or the patient continues to have signs of infection, particularly post-operatively, if you've placed the root canal filling, then it's very difficult to deal with that. You basically have to start the treatment again or look for other ways of managing the infection. Whereas if you have a medicament in the canal, you can simply open the canal up, wash out that dressing and place a new dressing, perhaps with a different material, to try and deal with the bacteria that are there. Now, a major theme that arose through these questions was to do with discoloration associated with Ledermix. Now, we know from the studies that have been done, and I've been involved in some of those studies myself, is that Ledermix can discolour teeth. And that's because of the tetracycline component of Ledermix paste. But it's all to do with the way you use the paste. The discoloration of the crown will not occur if the material is not placed in the crown of the tooth. In other words, don't leave any Ledermix paste within the coronal part of the access cavity. It's a root canal medicament, so it's important that you just place it in the canal and keep the coronal part of the tooth absolutely free of the paste. If there is any paste left in the crown, then we know that if the tooth is exposed to light, which will happen because teeth, particularly anterior teeth, are inevitably going to be exposed to light on a day-to-day basis for all patients, then discoloration can occur. The other major factor that, or the second major factor that leads to discoloration is the presence of moisture. So if we have an inadequate temporary restoration, or if we say have caries in the tooth where moisture can penetrate, or if we have an old restoration, for example, for an anterior tooth, there's an old composite restoration that's breaking down and you don't remove it, then moisture can get into the tooth and lead to discoloration. So the main factors, as I say, are material in the coronal part of the tooth, light, and moisture. And the moisture is largely related to temporary restorations or existing restorations that are inadequate. So if we take care during our placement of the Ledermix and take care to make sure there's no way that any excess moisture can get into the tooth, then the discoloration is likely to be minimal. So it's all about being very careful and not doing what I call sloppy dentistry. So from a technical aspect, if you've, say, prepared the root canal and you want to place Ledermix in there, I would normally do that with a spiral root filler. You'd place a very small amount on the spiral filler, place the spiral carefully into your access cavity, being sure that none gets onto the walls of the coronal part of the tooth, and you don't start rotating the spiral filler in the handpiece until it's well down into the canal. And then you take it down to within, say, 3 or 4 millimeters of the working length with your handpiece running in a forward direction. And I do what I call like a teabag action, sort of in and out a couple of times, just keeping it short of the working length. And then as I withdraw the spiral filler, I keep it rotating relatively slowly, keep it rotating so that you're not dragging the paste out on the spiral filler, you're actually pushing it down as you come out. And you may need to do that several times depending on the size of the canal. So just to reiterate there, just a small amount of the paste on the spiral filler, and then don't start the spiral rotating until you're actually well down into the canal. If you do happen to get some of the paste on the inside of the access cavity, then you need to clean it out before you place your temporary restoration. Now, I would initially, if there's a reasonable amount there, I would tend to use, say, a small excavator. The instrument I use is a 31 LS to scrape out any material that's on the dentine or on the walls of the access cavity. If there's only a very tiny amount, that's maybe like a little bit of a smear of the paste, then you really need to use something like a moistened cotton pellet. And you may need to do that several times to remove the paste from the walls. You could moisten the cotton pellet, say, with EDTAC, which is the final irrigant that I use, or you might choose to use, say, some alcohol on the cotton pellet. But I'd be very careful that you're not actually pushing the paste into the dentine, because that will mean that some of the tetracycline could be in the tubules and you won't be able to remove it. So it's going to be very light wiping action, and preferably with a moistened cotton pellet, either with EDTA or with the alcohol. If discoloration does occur, then I wouldn't be overly concerned. There'll be a temporary period where you need to advise the patient that the tooth is a bit discoloured and you can't deal with it immediately. You can only deal with it once the root canal filling has been placed. And then after that's been done, then you can do internal bleaching. And internal bleaching is a very predictable way of managing discoloration caused by materials such as Ledermix paste. And if you're interested in the internal bleaching, then I can refer you to a paper that I was involved in writing, which is in the Australian Dental Journal in about 2009. Now, the next theme that arose was post-operative pain, and somebody asked about how do we deal with post-operative pain after the pulp's been removed and you've placed Ledermix paste in the canal. Well, interesting that that question's asked, because it's very rare that I would have my patients come back with post-operative pain in that situation. It's certainly possible, but it is very, very rare. I think when a patient presents with acute pain in particular, then my approach is to try and do as little as possible without doing too little. So what I mean by that is I don't think you need to go to the full extent of preparing the canal at that initial emergency appointment. If you do, you're likely to increase the amount of inflammation because of the mechanical procedures that we go through. So the most severe pain situation will be your acute irreversible pulpitis. So basically all you need to do there is either remove the entire pulp or remove part of the pulp and then place the Ledermix paste in the canal. And then obviously dealing with temporary restorations and so on, and then get the patient back again about 4 to 6 weeks later after the inflammation has settled down. If there's acute apical periodontitis associated with the tooth, then again I would use the Ledermix. If it was irreversible pulpitis, it's the diagnosis of the pulp condition, or if it was a case of an infected root canal system with acute apical periodontitis, then again, in that one I'd vary things slightly, and I would typically use a mixture of Ledermix paste and calcium hydroxide, because we want to have a little bit more antibacterial activity because of the infected root canal system. So with the acute apical periodontitis, again, by minimising the amount of treatment you do in terms of the mechanical procedures, you are not increasing the inflammation, you're actually helping to decrease it. The inflammation in the periapical tissues will be partly addressed by the Ledermix in the canals through the triamcinolone, the corticosteroid component, being released from the paste and diffusing through the apical foramen. You can also help with any post-operative pain by the use of things such as non-steroidal anti-inflammatories, such as ibuprofen, very effective in reducing pain because of the anti-inflammatory actions. And ibuprofen also has analgesic properties. And I think part of the secret here is to try and preempt what pain the patient may have afterwards, so that if you think they're going to have a reasonable amount of pain afterwards, then get them to start taking the ibuprofen pretty much as soon as you finish treatment, because that then allows a little bit of time for the drug to be absorbed and distributed through the systemic circulation while the anaesthetic is still effective, so that by the time the anaesthetic wears off, the ibuprofen will be at peak levels. And then I would get them to take regular doses of ibuprofen. So I would use 2 tablets, that's 400 milligrams of, say, Nurofen or Advil, one of those types of preparations. So 2 400 milligram tablets, sorry, 2 200 milligram tablets, so a total of 400 milligrams, and to do that 4 hourly on the day that you start the procedure. Usually by the next day, they don't need to take as much. If the pain is really severe, we might want to also supplement that with some paracetamol with codeine, or it could just be paracetamol. And in that case, I would get the patient to alternate between the ibuprofen and the paracetamol. So both drugs can be taken at 4 hourly intervals. So we get the patient to take the ibuprofen first, and then 2 hours later to take the paracetamol, 2 hours later to take the ibuprofen again, 2 hours later the paracetamol, and so on. And that will maintain very good therapeutic levels of one of the drugs. So as one drug is kicking in, if you like, the other drug is wearing off. And so we can have very effective pain control. And that regime has been outlined in therapeutic guidelines in both the first version and the second version. And I believe most dentists in Australia would have that. Now, I was also asked to comment on a paper that was published in Endodontics and Dental Traumatology back in 1990 by Martin Trope, where he investigated whether there was any difference in the flare-up rate amongst teeth that have been dressed with calcium hydroxide, Ledermix paste, or formal cresol. Now, there are a number of issues associated with that paper, which unfortunately can give the wrong impression. So the conclusions were that there was no difference between the 3 medicaments in terms of the flare-up rate. Now, we need to know what was the definition of flare-up. Well, in this study, a flare-up was considered to have happened if the patient continued to have pain that led them to call the surgery for further treatment after the initial stages of root canal treatment, and this is important, they had also been prescribed ibuprofen at a level of 600 milligrams. So that's higher than we would normally be recommending. As I said before, I'd normally say 400 milligrams. But in this study, they were given 600 milligrams. So they already had some pain control mechanisms in place. Apart from that, there was no standardization of the cases or the diagnosis of the cases there were no standardisation of the teeth that were treated either. So there could have been anterior, there could have been premolars, there could have been molars. They could have been cases with irreversible pulpitis, or they could have been cases with infected root canal systems. Some of them had no apical periodontitis, some of them had chronic apical periodontitis. Some of the cases were retreatment cases. So we have a whole range of different conditions being treated. And we know now that we would not group them all together because they are quite different conditions. You just can't treat different conditions and lump them all together to study the post-operative effects. There are also variations in the way they manage the cases. So if a tooth did not have any apical periodontitis, so in reading the paper you would interpret that as meaning they had irreversible pulpitis, then they were only instrumented to a working that was 1 to 2 millimeters short of the radiographic apex. Whereas if there was apical periodontitis, then they went further. They'd go to between 0.5 and 1 millimeter from the apex. So we have different criteria for different teeth, and that can certainly change the inflammatory response in the periapical tissues. They use very large canal preparation sizes, much larger than I would certainly use. So that means there was quite a considerable amount of instrumentation of the canals, which can lead to further inflammation, as I said before. And then the 3 medicaments they used were used in very different ways. The former cresol was just placed on effectively on a dry cotton pellet, so the excess liquid was squeezed out, and that was just placed in the pulp chamber. The Ledermix paste was placed, in the paper they said, in the apical part of the canal using a paper point. Now that's a very ineffective way of getting a paste into a canal because most of it will stay on the paper point and come out of the tooth when you take the paper point out. And then thirdly, the calcium hydroxide was placed with a spiral filler. So that's going to be a much more effective way of getting a paste into the canal. So there are too many variables in this study to make it valid in terms of its conclusions. And I think we need to keep that in mind. So the conclusions that there was no difference in flare-up rate is really not valid. And so we can't use that study to justify anything, really. Now, the next question, and there was only one question about this, was to do with avulsed teeth. The question was, do you always start root canal treatment for avulsed teeth when you replant them? If it's a mature tooth, so a fully developed tooth, yes, definitely I would start root canal treatment immediately after I have replanted the tooth and splintered it. And the reason for that is to reduce the chances of getting external inflammatory resorption. And external inflammatory resorption needs 2 things for it to occur. One is damage to the external surface of the tooth roots, in other words, the cementum, and that can happen with avulsion. The second thing that's needed is bacteria within the root canal system, and that certainly can happen with an avulsed tooth. And we know that with avulsed teeth, when the teeth are fully developed, there's virtually no chance of the pulp surviving. So you have a necrotic pulp, so the environment for bacteria is certainly very favourable. So it makes no sense to leave that necrotic pulp in place in fully developed teeth. So we would take that out, and the ideal medicament to place is Ledermix paste. And we'd use that for about 6 weeks, and then we'll replace it for another 6 weeks. Using what we call a preventive approach to stopping inflammatory resorption. If it's an immature tooth, so a tooth that hasn't fully developed, it's got an open apex, there is a chance of revascularization of the pulp. It can occur in around about 30 or so % of cases. So with immature teeth, we do not start root canal treatment straight away. We wait and see if the pulp recovers. The only exception to that is if the immature tooth that's been avulsed also has a crown fracture. And the studies by Andreasen have shown that in that situation, then pulp recovery is not going to happen. So those cases, we would start root canal treatment straight away. And again, using Ledermix paste as our initial dressing to prevent the development of external inflammatory resorption. Now, there's a paper that I wrote in the Australian Dental Journal about 3 or 4 years ago in the supplement on dental trauma, and that paper directly addresses that issue of when to do root canal treatment to prevent external inflammatory resorption following trauma. The next question was about what are the possible consequences if there's accidental extrusion of Ledermix cement? Now, I actually was puzzled by this, and I think probably the person who asked the question meant extrusion of Ledermix paste, because we wouldn't be using Ledermix cement in the canal, so it's not going to extrude. So if Ledermix paste is extruded beyond the apical foramen, I don't think there'll be any consequences at all, really, because the triamcinolone component will help to reduce inflammation, so that if there's any reaction to that foreign material, it's probably going to be very, very minimal. Being a water-based paste, it will be rapidly removed from the periapical tissues, probably within a few hours, I would guess. Next is about when doing the root canal filling, does any residue of Ledermix affect the root canal cement that's used? Well, ideally there shouldn't be any residue of Ledermix paste in the canal before you do the root canal filling, because you want to get everything out of the canal, have a nice clean canal before placing the root canal filling. Apart from that, I would not normally go from a dressing of Ledermix paste direct to a root canal filling. I would normally have at least another session with a dressing where we use, if we've used Ledermix paste the first time, that would be because of pulpitis. Then at the second appointment, I would use a mixture of Ledermix paste and calcium hydroxide to have a little bit of insurance, if you like, that we have dealt with all the bacteria that are likely to be in the root canal system. So we're not just dealing with Ledermix. If it was an infected canal, my final dressing would normally be calcium hydroxide by itself. So again, we're not dealing with any residues of Ledermix in that case. But it all comes down to being thorough, so irrigating, renegotiating the canals to make sure that there's nothing left in the canal before you do the root canal filling. If there happens to be a little bit left there that you're not aware of, so inadvertently leaving it there, then it's not going to have any major effect on the root canal filling in the long term. That paste will gradually be broken down and removed, just like any, say, bits of smear layer that may be left behind because of just fluid movement through the tubules off the tooth. So I wouldn't be too concerned about that. Talking about mixing with calcium hydroxide, the next theme of questions was around that. And one question was, would calcium hydroxide reduce the effectiveness of the corticosteroid? Well, we don't believe so. The mixture, we refer to it as a 50-50 mixture because we use roughly half and half Ledermix with calcium hydroxide. In the diffusion studies that we did many years ago now, the addition of calcium hydroxide did slow down the release and diffusion of the antibiotic and the corticosteroid. That has some advantages in that it keeps the drug in the tooth for a longer period of time, but it certainly didn't stop it from being released and diffusing through the dentine. There's no evidence that's been found anywhere that the mix of the two materials will inactivate the corticosteroid. There was one paper published a few years ago that compared Ledermix with another similar product, a donor-based, and for the effects of the calcium hydroxide on corticosteroid, and another paper that was looking at the effects on the antibiotic component of the two materials. There were some major issues with the methodology used in those two papers, and one in particular was that there are only 3 samples of each, so it makes it very difficult to make any assumptions from that. So at this stage, there's no evidence that the use of calcium hydroxide affects the drugs, and contrary to that, actually there's good evidence that you increase the antibacterial activity by adding the calcium hydroxide to the Ledermix, and we have published papers on that in the past also. Now, before leaving the paste and moving to the cement, there were some questions raised about the use of Ledermix paste in primary teeth. One was, can Ledermix paste be used for pulpotomy in a primary tooth? Well, I guess theoretically you could do that, but I wouldn't recommend using the paste. I would use the cement form for a pulpotomy, whether it's a permanent tooth or a primary tooth. I don't think it matters. When you do a pulpotomy, same as when you do a pulp cap, whether it's indirect or direct pulp cap, partial pulpotomy or a cervical pulpotomy, you want a hard setting material, because if it's a paste, when you then place any other material over it, you're going to displace that paste. It's either going to be pushed into the remaining pulp, which could cause irritation initially, or it's going to be displaced away from the exposure site, and you would just have a smear of that material then on the surrounding dentine. So ideally you want to use a hard setting material, and that was the whole premise behind developing the Ledermix cement, so that you only needed to place one material. You didn't need to go back into the tooth subsequently to place your restoration. And then there were some other questions about whether Ledermix could be used in deciduous teeth. And certainly, yes, it can. If you're going to do any form of root canal treatment in a deciduous tooth, so say removing the entire pulp, or if the tooth is infected, then Ledermix paste could be used in the root canal system, just as it can be in permanent teeth. The Ledermix cement can also be used in primary teeth, as I just said, for pulpotomies, pulp capping, and so on. So that leads us on to Ledermix cement. There were questions around what are the main indications of using Ledermix cement. Well, again, I'll refer you to that little booklet that I mentioned earlier on for some more details. But basically, Ledermix cement is to be used when you want a hard setting material. So it could be for either an indirect or direct pulp capping, it could be for a partial pulpotomy, cervical pulpotomy, or even using it, say, as a sedative lining under a temporary restoration. So that's effectively an indirect pulp cap. You can use it as a temporary cement to cement temporary crowns in place following a crown preparation. So there are a number of uses for Ledermix cement, and I would particularly use it when you have teeth that present with reversible pulpitis, so a milder form of pulp inflammation, where you believe that by doing the procedure and removing the cause of the problem, that the inflammation is likely to settle down. And the use of the Ledermix cement will help that because of the components. So the initial release of the corticosteroid component, which will occur mainly over the first day, with the rest over the second and third day, will provide generally a very rapid relief of pain. After that, you have the effects of calcium hydroxide and the eugenol, which can also help to reduce the inflammation in the pulp. And that material can then be left in place. There's no need to go back into the tooth and remove it to then do your restoration. So that leads to the question then is, what's the protocol, say, for a pulp cap? And really, it's the same protocol for a pulpotomy or partial pulpotomy once the pulp has been exposed. I would, firstly, I do my conditioning of the dentine. Now, as an endodontist, I don't restore teeth in a definitive way, if you like. If I have a patient who presents with reversible pulpitis, and my aim is to do some conservative pulp treatment, so in other words, keep the pulp rather than removing it, then I will do my initial investigation of the tooth, so removing the old restorations and the caries and any cracks and so on. And then if the pulp is exposed, we'll make a decision as to whether it's a pulp cap or a partial pulpotomy or a pulpotomy. Provided we can control the bleeding, and I will just do that with cotton pellet with some saline on it and a little bit of pressure. I don't like to introduce any other chemicals there because they can give you a false impression about whether you've actually, the pulp has stopped bleeding or whether it's the material that has actually cauterized the pulp stump. So just some cotton pellet with saline and a little bit of pressure, leave it there for a couple of minutes, take the cotton pellet away. If the pulp has stopped bleeding, then generally that indicates you've reached a level where the pulp is relatively normal, or at least it's likely to recover. I would then do my dentine conditioning because as I said, I don't do the definitive restoration. I will do a glass enema, what I call interim restoration. My preferred materials there would be Keytac silver if there's no aesthetic problem. If there's aesthetics involved, then I'll use Keytac film. One of the reasons for using Keytac silver is it makes it easy for the referring dentist to remove subsequently because they can actually see the material because of the colour. So I do my dentine conditioning before I place my Ledermix cement lining. The reason for that is that if you do your conditioning, or if you were going to do a composite directly onto the Ledermix cement, the acid that we use for either conditioning or etching is likely to affect the material. And then when you wash the acid or the conditioner away, you're potentially washing out some of the active components of the Ledermix cement. So basically, once we place the Ledermix cement, we don't want to be washing out that cavity anymore. So we'll condition, or if you're using composite, you can etch, and then wash and dry the tooth as you would normally, and then place your Ledermix cement. And I find the easiest way to do that is to use a decal applicator. As I said, my protocol would then be, once the material is set, I would place my interim glass ionomer restoration. If you were going to place any other restorative material, such as composite or even amalgam, I would firstly place a thin layer of glass ionomer over the Ledermix cement before you place that other restoration. Largely to protect the Ledermix cement, but also just provides probably a more effective barrier between the mouth and the pulp. It's all about keeping bacteria out of the pulp. Now, some people have asked about the setting time for Ledermix cement and whether they could change that by altering the consistency of the powder and liquid that's mixed. Well, yes, you can. The more powder you use, the quicker it will set. So you need to have your dental assistant mix it to the consistency where you can effectively place it before it starts to set. But it's not all that slow. Maybe you need to wait a minute or two while it sets. And I think it's not really an issue in my hands, at least. Somebody did ask whether you could place another layer of the restoration before the Ledermix cement has set. Well, I would advise against that. Definitely, because it's just like if you use the paste instead of the cement, you're just going to push that unset material either into the pulp or away from the pulp over the surrounding dentine. So it's not going to be very effective. So you really need to wait for it to set first. You can also get the normal set and the fast set liquid. I tend to use the fast set liquid because it does make the material set a little bit quicker. Temperature can also have an effect. So if your surgery is warm, then the material is likely to set more quickly than if it's cold. The next question along those lines is, how long should you wait after you do a pulp cap? And basically the same would apply after doing a partial pulpotomy or a pulpotomy. So how long after doing the procedure and placing a provisional glass ionomer, how long would I wait before placing a more definitive restoration? Well, if a patient is coming with pulpitis, or even if there's no pulpitis and you happen to have exposed the pulp for some reason, I think you need to consider how long does it take for pulp to recover. And the symptoms, particularly if you use Ledermix cement, the symptoms go away very quickly. Now, I always say to my patients, the symptoms can go away for two reasons. One is because the pulp has got better. Secondly, because the pulp is necrosed. That can happen sometimes, even though we think it's reversible pulpitis. There is a little bit of subjectivity in terms of the symptoms reported by the patient, and that might mean that we sometimes make the diagnosis of reversible rather than irreversible pulpitis. If the pulpitis is truly irreversible, then the pulp will necrose. It's nothing to do with the material that we place there. It's the fact that the pulp has already reached that stage of being irreversibly inflamed. The other possibility is by doing the procedure, we're irritating that pulp further, and we may convert it from reversible pulpitis to irreversible pulpitis. So we need to be very careful in terms of how we manage the patient afterwards. I will say to my patients, if your pain goes away, that's great, but you need to come back and see me in 3 to 4 months' time so that we can reassess that tooth. And in particular, I want to do pulp sensibility tests to see if the pulp has actually recovered. If it has recovered, so it responds normally to, particularly a cold test is the best one to do at that stage, and the patient hasn't had any symptoms along the way, then that tooth is now ready to have a more definitive restoration placed. However, if the pulp does not respond at that stage to your cold test, then that could be indicating that the pulp is actually necrosed. And so I would be looking at taking a radiograph then to compare with my pre-operative radiograph to see if there's any changes. If I'm not sure, then I usually will say to the patient, let's leave it for another 3 or 4 months and we'll test it again. But if I am sure that there's been pulp necrosis, that's when we will do root canal treatment. So the idea here is not to do your definitive restoration until you know what the pulp response is, because it can go either way. And if it recovers, that's fine. If it doesn't recover and you've placed, say, a crown on the tooth, then you've got to cut through the crown, and that will compromise both the restoration and the tooth, and possibly your patient's thoughts about what's been done. So it just makes sense to give the tissues time to heal and make sure you reassess whether they have actually healed or not before you go to the next stage. Now, in terms of the definitive restoration, there are a couple of questions raised about the effect of eugenol that's in the Ledermix cement, whether that could affect the composite resin or the cement used to cement a crown if it's a resin-based cement. There are basically two thoughts on the effect of eugenol on composite resin. And the one thought is that the eugenol does affect the setting of composite resin. The other thought is that it does not. Now, many years ago, we're talking back in the sort of 1970s and 80s and even into the 90s, with the composite resins that were being used back then, there are studies that suggested that the eugenol did have an effect on the bonding. But with more recent studies, and we've just completed one of these studies through one of our student research groups about a year or so ago, we found that there was no difference whatsoever between teeth that have been treated with eugenol or zinc oxide eugenol prior to having composite resin bonded to it. And we used a shear test in an inch-round machine to test the bond strength. And other studies have said the same. So with more modern composites and the acid etching techniques that are being used and the bonding resins that are being used, it seems that the effect of eugenol on the composites no longer exists. So I'm not concerned with that. I'm quite happy to use things like Ledermix cement, and you're only using a very small amount of it too. By the way, you're not having to cover all of the dentine with the Ledermix cement. And if you are concerned about the effects of eugenol, again, that would be an indication to place a glass ionomer lining before you place the composite resin, as I mentioned before. There were a couple of questions raised about whether Ledermix cement would bond to composite. Well, the answer to that is no. There will not be any bonding between the Ledermix cement and composite resin. But that's not an issue. I'm actually a little bit surprised by those questions because we don't need every material to bond to every material. They are quite different in chemistry, and so we would not expect any bond to occur between those two materials. The next question was to do with deep decay. Can we use Ledermix as a base where the decay is extremely close to the pulp but no exposure? Well, yes, you can, definitely. That's effectively an indirect pulp cap, and the Ledermix cement is actually an ideal material to use in that situation. I would then cover that with glass ionomer before placing my definitive restoration over the top of that. There were a couple of questions regarding discoloration with the Ledermix cement. In the webinar, I mentioned that if you're using Ledermix cement as, say, a pulp capping material or partial pulpotomy material in an anterior tooth, say, following trauma, I'm not concerned about discoloration from the Ledermix there, because if it's covered with the restoration, then you're removing the effect of moisture. As I mentioned before, you need moisture, you need light. There's only a very, very small amount of the cement that would be used, say, to do a pulp cap or a pulpotomy. So the effect of light on a tiny bit of material that's surrounded and covered by glass ionomer and composite, it's very unlikely that you'll get discoloration from the use of cement, Ledermix cement. One question was discoloration of the composite resin that's placed over the Ledermix cement. No, I don't believe that there's any interaction between the Ledermix cement and composite resin that would lead to the resin discoloring. the Ledermix cement can lead to tooth discoloration, but not composite discoloration. One question was asking whether Ledermix cement is radiolucent or radiopaque. Well, it's slightly radiopaque, but generally speaking, once you've covered it with other restorations, you probably won't see it anyway when you take a radiograph. During the webinar, I talked about the pulp reaction under Ledermix cement, and one question was just to clarify that. Now, what we have seen in the literature is that when we use Ledermix cement, we generally do not get a dentine bridge forming. And I discussed how a dentine bridge is actually not needed following a pulp exposure, for instance. A dentine bridge doesn't do anything to protect the pulp. It's really just an indication that the pulp has laid down some hard tissue, and that's all. What we do see with Ledermix cement is that the underlying pulp is usually free of inflammation, whereas with some other materials there can be a layer of inflammatory tissue or even a layer of necrosis, such as after the use of calcium hydroxide. So many dentists sort of want to see a dentine bridge, but it's not actually necessary to have. What we really want is an inflammation-free pulp. Now, having said that, we will see in some cases with Ledermix cement that there can be some diffuse calcifications that occur. There might be a dentine bridge or part of a dentine bridge. There might be some other areas of calcification within pulp. But one of the differences with Ledermix cement is that it's only usually little bits of calcification, and that doesn't affect the ability to do root canal treatment in the future if that becomes necessary. Whereas with calcium hydroxide and materials like that, the laying down of hard tissue is generally a lot more complete, if you like, or more thorough throughout the tooth, and that can lead to complications with root canal treatment. Now, there were a few questions around the issue of mixing Ledermix with other materials. Now, one was to mix Ledermix paste with cry paste, I'm assuming as a root canal medicament. Well, there's really no logic behind that. Cry paste is a very irritant material. It's not one that we would recommend for use in root canal treatment these days, and I certainly haven't been recommending it for probably 35 or more years now. One of the other problems with cry paste, apart from being quite toxic and irritant, is that it can really discolor a tooth, and it can cause sort of a brown discoloration of the tooth. So where colour is an issue, certainly we don't want to use cry paste. But there's not much point in mixing a toxic material with a material that's not toxic, because, okay, you might use Ledermix to try and reduce the toxic effects of the cry paste through its corticosteroid, but that's not really rational use of drugs. So it would be, I guess, a case of inappropriate prescription and use of drugs. Another question, again, around the use of the paste was, can it be incorporated in the one visit elective root canal treatment, say to combine it with AH plus or BC root canal filling materials? Well, again, I certainly wouldn't recommend combining it with any of the root canal cements. You probably will find that the root canal cement doesn't set as it should if you were to do that. If it did set, then the incorporation of the Ledermix components within a hard setting material means that they're probably not going to be released, and therefore they are unlikely to be therapeutic. Now, I say probably and unlikely because no research has been done on it that I'm aware, and really it just doesn't make sense to try and do that. So I doubt that there will ever be any research on that particular topic. The third question related to mixing materials was to do with the cement, and the question was about mixing the Ledermix cement powder with resin-modified glass ionomer bonding resin to effectively get what this person referred to as a light-cured Ledermix. Well, again, I see no rationale to doing that, and certainly there's been no research to justify doing it. It might mean that you have a faster setting material, but the problem is that you're not getting the effects of the eugenol because you're not using the liquid component of Ledermix cement. I'm not sure whether the calcium hydroxide would be released afterwards as well. That would need to be researched. And likewise with the corticosteroid component, if it's incorporated within a resin, it may not be released, and so you might not actually get any effect of it from a therapeutic point of view. So, again, it's an inappropriate use of materials. I don't think you'd find any manufacturer recommending a combination of part of their material with part of another material. It doesn't make sense, and there's certainly no scientific rationale or evidence to support that type of thing. The last lot of questions that I'll address are all to do with an alternative corticosteroid antibiotic component. So Ledermix we would class as a corticosteroid antibiotic compound. There are several others on the market overseas, and one in Australia, the odontopaste and odontocin materials. A number of people said that they used odontopaste when Ledermix was not available, which is a reasonable thing to do. But certainly a lot of the comments I've had is that the odontopaste didn't seem to be as effective as the Ledermix in terms of pain relief. We had to use it in our school as well, and I have used it in my practice. I would agree, and it's very subjective and certainly not evidence-based to say that it didn't seem to be as effective, but that was the impression that we had. The difference between odontopaste and Ledermix paste is in the antibiotic component. Odontopaste has clindamycin, and it's also at a higher concentration. It's 5%, whereas Ledermix has the temeclocycline at 3.2%. So the higher concentration might be seen as an advantage, but one of the things one of the big advantages of using the tetracycline in Ledermix paste is the binding effect with dentine. That slows down the movement of the drug through the dentine tubules. So the drug is held in the tooth for a longer period of time. And that means that the bacteria that are in the dentine tubules are exposed to the drug for a longer period of time, and therefore more likely to be effective in inhibiting and killing those bacteria. And some recent work that we're doing, we haven't finalised the work and it's not published yet, but we've been looking at diffusion of these materials through dentine, and what we've found is that the clindamycin diffuses very, very rapidly compared to the temeclocycline in Ledermix. So I see that as a disadvantage of that material. The other really important thing is that these other materials don't have the research to back up the claims that are being made about them, and that means that effectively there's no evidence to support them. We can make some extrapolations from the research that's been done on Ledermix, but once you change components of any material, it's not the same, and therefore you really can't make any strong claims from a scientific point of view. Anything that is said is just going to be purely anecdotal, based on individual people and how they see the material in their day-to-day use of it. So I'm a firm believer that we should do evidence-based dentistry, and whilst we do lack evidence for some things and we don't necessarily have the highest level of evidence for everything that we do, we have to take the evidence that we do have, and that means you need to read the literature, you need to be able to interpret the literature or listen to people who can interpret it for you, and then apply it in your practice. So if the literature is not there for any particular material, whether it's in endodontics or restorative dentistry or any part of dentistry, if there's no literature there, then you really have to question the claims that are being made about the material. So that really brings us to the end of the session. As I said, there were almost 100 questions that were sent through during the webinar and some afterwards. I hope I've covered all the queries that have been raised. I would encourage you again to have a look at that little booklet which I mentioned before, the Ledermix materials. It is available freely on the internet. You can get hold of that, as I said, just by doing a simple Google search. If anybody does have any specific questions, then I'm certainly happy to try and answer them by email. through my email address at the university, which is paul.v.abbott@uwa.edu.au. Thank you for your attention.